this is the vision we have. We are at the end, at the beginning of a liberating era. The knowledge economy, the computers, they liberate everything. They give us true independence. And if we don't make use of it, and again keep following the older model, they are missing a huge opportunity. That's the whole point. Thank you.
Thank you, Professor Kirti. I think to please go ahead with her presentation. I'm sorry we had to interrupt you earlier. Just a moment, Kate. I think we didn't get the audio from you. Can you speak up so we can check?
Yeah, I had muted it before. Sorry.
Great. We can hear you, so please go ahead.
Great. Well, first of all, thank you so much to Mobile Plus for allowing me to present our research today. And thank you all for being here. I'm sorry that I can't be there in person, but I'm delighted to be able to Skype in and share more about our research with you. My name is Kate Otto, and I work with the World Bank. And I work as part of the World Bank conducting the eTransform Africa initiative. And this initiative is part of the bank's Africa region, and it looks at the ways in which ICT is transforming all different sectors. And I work specifically in the health sector, and even more specifically in trying to build an evidence base for proving or disproving the utility of mobile health tools. I think that oftentimes tools seem great from the beginning. They seem to have great short-term benefits, but what we're interested in is if there are long-term benefits and changes in health outcomes to using mobile health tools. Can we go to the next slide? Thank you. If at any time it becomes difficult to hear me or I'm speaking too quickly, please interrupt and let me know, and I'll change. All right, so our research team is not only the World Bank, actually. It's only myself and Dr. Feng Zhao, who is the eHealth coordinator for the Africa region. Most of our research team is from Addis Ababa University, because when we began this study, we knew it would be very important to work with folks who have a great relationship already with the health sector in the country we chose to work. And not only do they have a great health sector relationship, but Dr. Asfaw Atnafu and Dr. Solomon Shifarao both work for the Center for Health. There is a Center for eHealth at Addis Ababa University, and they represent the schools of medicine and public health. And we also have the Dean of the School of Information Science on board with us. So we started off with a great team of people as we put together our thoughts for this research. You can go to the next slide. So in working in Ethiopia, it's an interesting place to work, because while there's been enormous progress in health outcomes and changes within the country, when you compare Ethiopia to other countries, you can still see that there's even more progress to be made. So it's an enormous country with over 80 million people. Fertility is still very high, over 5 children per woman on average. Contraceptive use is still very low. And although there's been success in decreasing maternal mortality, it still remains very high at 73 per 100,000, which constitutes 21% of all maternal deaths. And 85% of those reasons for those deaths are complications that could have been avoided. For child health, the situation is not much better, 14 child deaths for every 100 children, which is heartbreaking, especially to know that 90% of those deaths are absolutely preventable with simple and oftentimes free health care. Even vaccines in Ethiopia are free now. So there's huge challenges, which made us think it might be a great place to work. Also, the government has instituted what's called the Health Extension Workers Program in the past 2 years, which has deployed 2 health extension workers, community health workers, out to every single kabele, which is a village, which has anywhere between 2,000 and 5,000 people. This is revolutionary in Ethiopia to have that kind of coverage of human resources for public health, and it's great for the idea of a study because there's human resources available to work at a village level with us. And although the Health Extension Worker Program has been successful, of course there's still challenges. there's inadequate capacity because 2 people for every 5,000, of course, is still difficult to cover everyone. Low service utilization, low accessibility to care, low availability of supplies. There's certainly a lot of obstacles to care. The one that we are focused on, change the slide, is communication. There's some things, a lot of care is free. In fact, all primary care is free. Maternal and child health care is free. Cost is not always an issue. Of course, things like transportation are. However, more often than not, there are health services available. It's a matter of people either not knowing to go for them or not coordinating to go for them. We found that consistently in our interviews with the health extension workers, communication was a problem between patients and health workers and between health workers and the government. So, go to the next slide. So with the communication, we were thinking, well, is this even feasible to do a study here? We were warned by many people that it would not be feasible. The network is not strong enough in Ethiopia to do a study about mobile health. However, and I recommend this report to everybody, the Solowave Consulting did a report recently called mHealth Ethiopia. They discovered through extensive interviews with health extension workers that mobile penetration is low in Ethiopia, 10%. However, over 90% of health extension workers have access to a mobile phone, and more than half of them are already using it every day to do their job without being paid. They use their own money to send messages and to make calls. Now GSM networks cover almost 70% of the country, as well as CDMA networks. So it's actually quite connected, and actually ended up being a perfect place to conduct this study. We can go to the next slide. So with the idea of communication in mind, informing our hypotheses and the objectives of the study, we thought, what can we actually look at within maternal and child health that would show us where communication problems maybe could be resolved with the mobile network and mHealth software. So we're looking essentially at contraceptive stops, because there are enough in the capital. It's a matter of whether or not they get out to the village level. Increasing antenatal care visits. There are health extension workers available to do these visits, but they don't get done oftentimes because of coordination. Same with clean and safe delivery. People are there and they're trained to be able to do this work, but they just don't get there at times. Registering children to be immunized. Again, vaccines are free, they're available, so maybe communication is one reason why they're not coming to get them. And probably the most common thing we heard was the referral system is very broken. So when people need to seek higher care, they go to a facility and no one knows that they were coming, so no one is ready to see them. There's no doctor there to see them, even though a doctor is in the area. Again, it's coordination and communication. So these are our hypotheses that mobile phones can possibly improve this. Next slide. So just a bit of our research design. We've done a baseline data collection already over the past few months with hundreds of pregnant women and also with health extension workers. What we're going to be doing is we basically have randomly selected 3 different woredas. Woredas are districts in Ethiopia. 3 randomly selected, 2 are intervention and 1 is control, and we have comparable endpoints, which I'll review in a bit. And that's going to be complemented with not only the quantitative data, but qualitative interviews with both women and with extension workers. Next slide. As any of the researchers in the crowd know, it's very important that we randomize the selection